Namaste. Greetings from all of us at Apollo Hospitals. This is Dr. Srinidhi Chidambaram, and I'm very happy to see all of you again. I hope you all have been well and in the best of health and spirits. Sometimes a major health condition begins with the mildest symptoms, but when you are not aware of what your symptoms may indicate, you end up delaying seeking immediate medical attention, and this often leads to worsening of the disease and more severe outcomes. That is why we at Apollo Hospitals have been regularly hosting these health awareness sessions to give you factual information straight from our top experts so that you can be fine-tuned to your health all the time. Today is World Stroke Day. Let us mark this day by gaining awareness about a disease where every minute counts, and the longer it goes untreated, the greater the potential for damage and disability. Stroke. In brief, a condition where blood supply to part of your brain is interrupted or reduced, preventing your brain tissue from getting oxygen, and then they begin to die in minutes. Stroke damages the brain, but the long-term effects really depend on how quickly you take action, which parts of the brain are affected, and what type of blood vessel is involved. So, to give us his valuable views on this very, very crucial topic, I'm very happy to welcome Dr. Srinivasan Paramasivam. Dr. Srinivasan Paramasivam is a leading expert in the field of neurosurgery with particular expertise in cerebrovascular and endovascular procedures. Dr. Paramesivam's academic journey began with several prestigious institutions, starting with his MBBS at the Madurai Medical College, which is affiliated with the Dr. MGR Medical University, India. He then earned his Doctor of Medicine degree from the New York State Educational Department, followed by his MCH in Neurosurgery from the renowned Madras Institute of Neurology at the Madras Medical College. His exceptional surgical expertise was further recognized when he was elected as a member of the Royal College of Surgeons of Edinburgh in 2006. Advancing his specialization, Dr. Paramasivam completed his fellowship in endovascular neurosurgery at the St. Luke's Roosevelt Hospital, affiliated with the Columbia University College of Surgeons and Physicians in New York. His international career includes serving as a neuroendovascular surgeon at the same institution and as an assistant professor of neurosurgery at the prestigious Mount Sinai Medical Center in New York. Currently, he leads as the senior consultant neurosurgeon and head of neuroendovascular surgery at Apollo Hospitals, Chennai, where he continues to push the boundaries of superior neurological care. He's also a prolific researcher and educator with more than 30 peer-reviewed publications and 12 book chapters, and is involved in several clinical trials as well. Thank you so much, Dr. Paramasivam, for joining us here today.
Namaste, ma'am. Thank you for the kind introduction, and it was wonderful introduction by you, and I'm so happy to be part of this program to create awareness on stroke.
Thank you, Doctor. So let's begin by asking you the most basic question. What is a stroke? What exactly goes wrong in the brain when somebody has a stroke?
Yeah, stroke is commonly a misnomer. People have been confusing stroke as heart attack and other diseases that affect the body quite acutely. So I want to popularize the term brain attack similar to heart attack so that people are clear about stroke. Stroke is brain attack, which is a sudden dysfunction of the brain because there is either loss of blood supply to the brain or bleeding inside or just outside the brain, causing the brain to function inappropriately or stop functioning all of a sudden. That is what a stroke means.
Right. What are the different types of stroke, and are there different symptoms for each type?
Yeah, stroke is a broad term. It's an umbrella term which involves a lot of the dysfunctions that happen related to the blood supply to the brain. It may affect a small part of the brain, causing a small stroke or an evolving stroke or a mild symptom. Or it can affect a larger part of the brain, causing a major disaster. Basically, there are two types of stroke. Just for a common man to understand, the brain is one organ which is very, very active in its function and it needs constant blood supply. Brain cannot store energy which for it to function for hours. It needs the regular blood supply to be flowing regularly, and for 5 minutes if there is no blood supply, the part of the brain would die. So practically, one type of stroke is where there is no blood supply to the brain. The block may be in a major blood vessel in the neck or in the brain, or a small blood vessels inside the brain part, causing what is called an ischemic stroke. This is the major cause of stroke. About 80% of all strokes are ischemic stroke, which means lack of blood supply. The second type of stroke is actually a hemorrhagic stroke. Hemorrhagic stroke is called bleeding. Bleeding in Latin term is called hemorrhage. So that's why it's called hemorrhagic stroke. The bleeding can be inside the brain or surrounding the brain, outside the brain, causing a sudden dysfunction of the brain. So these broadly are the two types of stroke that we see in human body.
Also, what causes a stroke is something I think which is very important because I think people should know that there are risk factors and some of them are in fact modifiable.
Yes, correct. I mean, there are so many risk factors that cause stroke, and the risk factors, to make it very simple, they are similar to the risk factors that cause the heart attack. Like the brain attack, the heart attack too is caused by lack of blood supply to the heart. Likewise, the similar risk factors applies to the brain as well. The common risk factor are usually uncontrolled diabetes, uncontrolled high blood pressure, uncontrolled high cholesterols. So basically the lifestyle diseases like diabetes, hypertension, high cholesterol, along with other factors like, obesity, chronic smokers, and other congenital factors. There are some people who are prone to develop stroke, who the stroke runs in families. So these are the common risk factors associated with stroke. And apart from all this, the lifestyle is one of the common risk factors. Today's lifestyle involves a lot of junk food with less mobility, and lack of activity as well leads to increased risk of stroke. And these all apply to heart diseases as well. So similar to heart disease, you can remember anything that causes a heart attack practically can cause a brain stroke.
So in summary, it really boils down to lifestyle, as many diseases do.
Correct.
So there are quite a few myths and misconceptions which abound about stroke. So for one, people think that maybe a younger age or women may not get stroke. So what, in your practice, what are the common myths and misconceptions that are there in people's minds, which I think it is our duty to debunk?
The most common misconception that people have is understanding stroke to be a disease that may not happen to them. It is somebody else's disease. No. 1 in every 6 individual in their lifetime will have a stroke, which means one of our family members can have a stroke. One. Second thing is, the stroke can be easily identified, but unless otherwise somebody has a high index of suspicion, it's very hard to pick up a stroke, because stroke is a painless disease. It doesn't cause you pain. Like a heart attack, which is the ischemia of the muscle, causes a lot of pain, whereas brain is one organ which doesn't have pain receptors. The brain senses every part of the body's pain, but brain is painless, and anything that affects the brain is completely painless. And for example, if somebody develops a stroke, practically they would be lying in the bed without complaining anything. You ask them to move, they may not be able to move. They may not be able to move their hand or leg, or when they stand up, they may have an imbalance and they may not complain at all. So high index of suspicion and awareness, and people knowing that somebody in their family is having a stroke is very, very important to pick up stroke and bring them to the hospital. The other myth is stroke is an old age disease. Yes, stroke in general, is a disease of the old age, because as we get older, we develop diabetes, hypertension, and other risk factors, we do develop it. But today, we are seeing strokes in more younger individuals and in women as well, especially with increased obesity and the dietary pattern changes and sedentary lifestyle. And most important thing is a work stress. Everybody are involved in a lot of stressful environment, and they don't take care of their blood pressures. A lot of them don't even know they have a high blood pressure till they come to the hospital with a stroke. So all these put them at the risk of stroke. So stroke is not an old age disease. It is a disease that can affect you at any part of your life. Though at younger age you have a lesser risk, but there is a definite risk of stroke.
Right. I think now we will move on to recognizing the stroke, which again is also about why is it important to recognize it and how do you recognize it?
Yeah, the stroke is one disease where if you have awareness, it's very easy to pick up. You don't need an advanced gadget like doing an ECG to identify a heart disease. Likewise, you don't need anything. Just by a clinical exam, you will be able to recognize it. Whenever I give a talk to a general physician, I tell every general physician to educate their patients about stroke. Stroke, you can pick it up if somebody has, like not able to understand your speech and they are not able to talk back. That is a sign of stroke. You ask them to smile. If there is deviation of the angle of the mouth to one side, then that's a sign of stroke. You ask them to lift their hands. If both hands are not symmetric, if a hand is falling down, if they have a drop or a drift in the hand, that's a sign of stroke. If they are not able to stand or walk, that's a sign of stroke. If they have some visual disability or vision loss, sudden vision loss in one eye or both eyes, that's a sign of stroke. You ask them to stand and walk. If they have an imbalance while walking, that's again a sign of stroke. So these subtle neurologic signs, if you pick up early before they develop a permanent complete deficit where they are not even able to move out of the bed, it is easy to treat them and cure them completely. So understanding the signs of stroke, picking them early, bringing them to a comprehensive stroke center is extremely important in curing the stroke disease.
And why is it important to do that so quickly?
Yeah. Let's talk about the ischemic stroke. Ischemic stroke is extremely time sensitive. We are born with fixed number of neurons. And if there is a stroke, lack of blood supply for about 5 minutes, our neurons start dying. They start dying at a very, very rapid rate. We lose about 1.2 million neurons every minute that passes by. Though we are born with billions of neurons, our neurons die much, much quicker. When there is lack of blood supply, for example, a major vessel occlusion, first, a core of brain starts getting affected. The surrounding region is being perfused or supplied by collaterals. Collaterals are the surrounding blood vessels start supplying and they survive to some time. That is called the penumbra zone. You just imagine this is a core, there is a big penumbra around it. If we don't do anything about it, the entire penumbra becomes a stroke and the whole hemisphere or the whole part of the brain would get affected. Before that happens, we need to intervene, re-establish the flow and prevent the penumbra, that is the surrounding brain, to become a core of the infarct. In that way, we can save the patient and the patient can recover very well, and in about say 2-3 months he'll be back to normal doing his routine work. So stroke is an extremely time sensitive disease. Every minute that passes by after somebody develops a stroke becomes very sensitive. Each minute lost is brain lost, and this brain lost is a permanent loss, and they need to be aware that each minute that passes by after a stroke develops is the brain that is lost, which will never be recovered. So time is the essence in this disease.
Well, you mentioned briefly that people should go to a comprehensive stroke center. Now, I think this is one of the key factors that we need to discuss a bit in detail because there is often a misconception that, as long as you go to some doctor, to some hospital, nearby to on your street. That is what counts as going and seeking medical help. But unfortunately, we know that that's not quite true. So I think there comes the concept of what is a stroke-ready hospital? Where should you go? I think this is one area where people are really unaware. And there is really no point in going to your neighborhood doctor who does not have the diagnostic capabilities. So I think it'll be very useful if you could tell our viewers where should you go if you suspect a stroke?
Absolutely. This is a very valid question. The healthcare systems across the globe are differently set up in different parts of the world. For example, in the Western countries like the United States and Europe, they have a very comprehensive network of hospitals and the healthcare system and the pre-hospital care where the care can be kind of streamlined. But we live in India where the healthcare system is a little haphazard or wayward, where most people tend to go to their nearest primary care healthcare provider. For example, this being a painless disease, somebody with the arm drift or a weakness of the hand, he would go to a primary care physician. I'll just start with the scenario. He just goes to a primary care physician. He just stays outside his OPD. These are real life situations which we have encountered. He would sit in the OPD waiting to meet the physician for about 1 hour, and then he would meet the physician. By the time physician meets him, significant amount of time is lost. Then comes the story. He refers him to a scan center where he goes outside the hospital searching for a scan center where the technician and the other associated staff are not aware this is a stroke patient. They would just make him wait again there for another half an hour, 1 hour. They would do the scan, and by the time the scan gets reported and comes back to the primary care physician, the golden period of treatment of the stroke is gone. And this patient would be disabled for life and we will not be able to help him. Whereas comprehensive stroke center is the hospital where the emergency rooms are available, and as soon as the patient comes in, the emergency room is aware that somebody is having a stroke. They would alert the entire team. The team involves the radiology, imaging physicians. The team involves the pharmacist. The team involves a neurologist. The team involves a neuroendovascular surgeon. All of them are alerted at the same time so that the scan is done within the next 10 to 15 minutes and it is interpreted immediately. And in most situations, if it is an ischemic stroke, thrombolytic therapy, which is a clot-bursting medicine, can be given. That's what we do at Apollo hospitals. We give the thrombolytic therapy in the scan room itself so that the treatment is initiated. And within the next 20 to 25 minutes, we move the patient to the cath lab to do mechanical thrombectomy. So these are the advanced treatments which can happen in a very quick time if the patient reaches a hospital where all the facilities are available. So it is extremely important and mandatory for the patient to come to a hospital where all the equipments, the specialist and the scan machines are all available in one center. That's what we call it as a comprehensive stroke center.
Right. And I might add here that even from the outcomes and process measures, we also track timings, like the time when the patient reaches the emergency to the thrombolysis and the time from the arrival to the emergency and when the CT or MRI is done. And these are kept within international benchmarks. So tracking improves the efficiency. So I think that's another angle with stroke-ready institutions.
Absolutely. We call those as the door to needle time and door to puncture time. And we keep track of it.
Yes. So we'll now move on to what you described briefly now on thrombolysis and mechanical thrombectomy. I think if you could give us a little bit of insights into what these treatments are.
Yeah, as far as the ischemic stroke treatment is concerned, any patient who was last seen normal within 4.5 hours of the onset of stroke, if they come to the hospital, what we give is a thrombolytic medicine. Thrombolytic is a clot-bursting medicine which is given intravenous. And we have two different types of drugs. In the past, we used to give a bolus dose and then give an infusion. Today, we have tenecteplase, which we just give it as one shot bolus. And if it lyses the thrombus, we can see the patient improve right in front of our eyes. That is called thrombolysis. And the number you need to remember is 4.5 hours from the time when the patient was last seen normal. And the second type of treatment we have is called mechanical thrombectomy. This is a very advanced treatment wherein we go inside the blood vessel, either from the groin or from the wrist. We go inside the blood vessel all the way up to the clot, and we are able to retrieve or remove the clot to re-establish flow of blood in the brain. This is called mechanical thrombectomy, and we have various techniques for this mechanical thrombectomy. To understand which patient is eligible for which treatment, we have advanced imaging. We first do an imaging. We do a CT scan with CT perfusion or a CT angiogram or MR angiogram with perfusion. These are advanced imaging based on the time interval at which they present. We do this advanced imaging and select the procedure for the right patient, and then we go with the plan. And all this are possible because we have a team which is preset to react to the stroke patients. We have the team which is already primed and they know what to do. Each one has their roles and responsibilities. For example, today, a stroke patient comes to the emergency room and we do a scan, we make a decision. Within the next 10 minutes, I can have the cath lab ready along with all the equipments. And once the patient is moved to the table, we'll be able to puncture in 20 minutes from the time we do the scan and interpret the scan. So these are the in-house specializations we have so that we are able to offer treatment without wasting much time.
And for mechanical thrombectomy, what is the time frame within which it is likely to be successful?
Generally, for every patient who was last seen normal within the first 6 hours from the onset of stroke. See, for example, we don't know when exactly somebody is developing a stroke. We take the landmark, benchmark as when they were last seen normal. From that time, if it is within 6 hours, every patient we offer mechanical thrombectomy. Between 6 hours and 24 hours, we select the patients who will benefit. In the beginning, I spoke about the core and the penumbra. There are a subset of patients who will still have penumbra beyond 6 hours. We select them with advanced imaging, either MRI perfusion scan or a CT perfusion scan. And based on those imaging, we select those patients and we offer thrombectomy. So the number you need to remember here is for mechanical thrombectomy, the time interval is 24 hours.
Is there any role of AI in stroke management these days?
Yes, the AI has been helping us over the last decade. And over a period of time, we have improvised on its usage and we have come a long way in terms of artificial intelligence usage. People have been looking at what is really causing the delay. One is a pre-hospital commotion. That is, the emergency services picking up the patient, bringing them to the ER, which is beyond our control, which differs from place to place and based on the support system and based on the ambulance service. Whereas inside the hospital, everything can go faster. But there are some regions where the system can be processed much better, and that's where the AI come into picture. That is interpreting the images precisely. For example, we do a CT perfusion or MR perfusion. It needs a specialist to sit and read all the images and then say that, yes, this patient can be benefited by doing a thrombectomy. He has a small core and a large penumbra, and the volume of the tissue that is at risk and the volume of the tissue that is already damaged. All these calculations is laborious and it is time consuming. So we have implemented what is called an rapid AI, which is an artificial intelligence software. And this system practically interprets the images in a very, very quick time, practically in no time. That is, as soon as the images are taken from the patient, it is automatically fed into the system. And this software interprets and gives us an alert. See, the way the software helps us is, this software is linked to our mobile phones. All the caregivers team, the neurologists, the neurosurgeons, the interventionalists, all of us are hooked up to this system through an app. And we get an alert on the app saying that there is a specific beep for patients who can be benefited with mechanical thrombectomy. So as the imaging is going on, we get a beep saying that there is a potential patient for mechanical thrombectomy, and immediately the team gets alerted and everybody gets on their toes and get things moving even before somebody gives them an instruction. In this way, the AI has made a significant inroads into the stroke care.
Right. Um, Finally, we move on to the stroke rehabilitation. Now, what is the role of rehabilitation and exercise post-stroke? Does everybody need it, and are there any advancements there?
See, with the significant advancements we have been achieving with stroke treatment, we are able to cure in about, say, 60 to 70% of the patients. And a good number of them, good number of this 60 to 70% are completely normal, and they get back to their routine life, and they get back to their routine activities and work and everything. But there is still a 30 to 40% of patients who are disabled to various levels. Some have mild disability, some have larger disability. Unfortunately, brain is one organ that does not grow. You cut a skin, it grows. You cut a hair, it grows. You cut a liver, it grows. But unfortunately, brain is one organ which cannot grow. So what we do with the rehab is we re-establish the functions of the last part of the brain by what is called neuronal plasticity. The available brain tends to learn the function in a new way, like a child learning to move, learning to do a particular maneuver and movement. We tune the surrounding normal brain to take over the function, which may not be 100%, but still it is possible to get to a good functional level by this neuronal plasticity. To get to this neuronal plasticity, rehabilitation is a very, very, very important step. And this rehabilitation will be a physical rehabilitation and an occupational rehab as well. And these two combine together along with the robotic physiotherapy. Robotic is made inroads significantly with regards to fine motor control and movements. And with this rehabilitation process, patients can get back to near normal function or to a good functional level compared to what they were left with the stroke.
So finally, what would you like to say to our viewers on this occasion of World Stroke Day? What is the take-home message?
Yeah, the take-home message is everybody should be aware that stroke is a deadly disease. When somebody is affected in the family with the stroke, not only the patient suffers, the patient's productivity goes down and the patient suffers, the caregiver suffers a lot more. Caregiver cannot go to his office. The caregiver's work is affected and their financial burden to the whole family is significantly high. So in this situation, identifying stroke becomes a key factor. Identifying stroke by picking up the subtle signs of somebody not able to move, somebody not able to talk, not able to speak, not able to stand or balance. If there is a vision loss, pick them up immediately, take them to a comprehensive stroke center where the best possible treatment can be offered. You have a best 60-70% chance they could get back to their normal life. So the burden to the whole family is significantly reduced.
Right. So thank you so much, Dr. Srinivasan Paramasivam, for this wonderful session. Viewers, I do hope you found the session useful. So 2 important messages on World Stroke Day from Apollo Hospitals. One is it's not all doom and gloom. You can completely get cured from a stroke provided symptoms are recognized early and you seek the most appropriate care at a stroke-ready hospital. And secondly, there are risk factors which are largely related to lifestyle, so you can do your bit in modifying your risk as well. And do remember that we at Apollo Hospitals are always available. Our experts are available 24/7 for you to seek advice, to consult, and to seek emergency care. So every minute counts. So take care and see you all soon. Thank you.